Good afternoon, everyone, and welcome to the Montana Healthcare Foundation webinar, Evidence-Based Practices, Overview of Problem-Solving Treatment. My name is Libby Ethier, and I'm a project coordinator at the National Council for Behavioral Health, and I will serve as your moderator today. Before we begin, I'd like to draw to your attention some important webinar logistics. Today's webinar is being recorded, and you are currently in listen-only mode. If you are listening on your phone, please enter on your telephone keypad the audio PIN number from the control panel on the right of your screen. You may send us questions at any time during the webinar. Simply type your question into the dialog box on the right and send it to the organizer. Depending on your question, we may answer back to you, interrupt the speaker to ask the question, or save it for the end. We will answer as many questions as time allows. Following the webinar, we invite you to complete a short survey. If at any point during the webinar you experience technical difficulties, please call Citrix Tech Support at 888-259-8414. At this point, I will turn it over to Joan King.
Hi, good afternoon, everyone. It's great to see so many of you on this webinar this afternoon. This is the first of several webinars where we're moving from focusing on financing and business plan development, focusing on clinical care in integrated settings. And I am delighted to have with us this afternoon to do this webinar Virna Little, who many of you have met as she's often on the road with me in Montana or on the road by herself, and also Eunice Kim. They are going to launch us into talking about problem-solving treatment and evidence-based practice for use in integrated care. Virna.
Yes, good afternoon, everyone. Thank you so much for letting us be a part of your day. And what we would like to do is really make today interactive. We know that some of this is going to be new information, and we really want you to leave the webinar with not only an understanding, but the ability to have asked questions about what goes on in your practices and with your patients and how you might incorporate some of these skills into the work you do every day with patients. And I'm joined by Eunice, and Eunice is a depression care manager and an implementation specialist on my team. So she not only teaches this information, but she actually uses problem-solving treatment every day with her patients. And so she is an excellent person to have a conversation with, to ask questions, and to be able to really do a deep dive if you have a particular question around how this might work in your practice. So I'm just going to ask that you advance the slide to the next slide. So we wanted to talk very, very briefly just to give everybody an overview of what collaborative care was. Problem-solving treatment is an evidence-based model that's used in conjunction with collaborative care. And collaborative care is a very specific evidence-based model for caring for patients with depression in a primary care setting that is very measurement-based. So it is using the PHQ-9, which we'll talk a little bit about, very measurement-based, looking for particular outcomes, and then stepped care, meaning that you're making adjustments and really treating to target. And you are introducing, next slide please, some folks to your primary care team. So you have your primary care provider, you have a depression care manager, and you have a consulting psychiatrist. And these folks are added to your primary care team, with the primary care provider really being, we like to say, the captain of the ship and overseeing the patient's care, really collaborating with the behavioral health providers, providing collaborative care. Collaborative care is often referred to as IMPACT. You'll hear that term, and that is improving mood, promoting access to collaborative treatment. That is really the name of a large research project that happened in the late 90s, early 2000s, that had 1,800 patients, over 400 primary care providers, that for the first time really identified and treated a mental health diagnosis in a primary care setting, which was depression in seniors. So that's really changed, but that really started all of the integration work, and a lot of the work that all of you are doing really came out of the impact trial and really the beginning of providing behavioral health services and primary care is a real focus. And so when you hear collaborative care, we are actually referring to the evidence-based model that introduces a primary care provider, or excuse me, a consulting psychiatrist and a behavioral health care management person into the primary care setting. For many organizations, the behavioral health providers in the health centers really serve as the depression care managers and will be using this model and problem-solving treatment with their patients who have depression. Next slide. So when you look at the collaborative care team approach, this is what it looks like. So you can see the care manager and the consulting psychiatrist are new roles. And we really just wanted to give you an overview so that when you hear the term collaborative care, you'll have an understanding of what the model is. And when we talk later about problem-solving treatment, you'll see references often to collaborative care because it really was developed for use in collaborative care settings. And one of the nice things, and Eunice will certainly talk about it a lot more, is one is how effective it is in primary care settings and how when used with patients that you're going to see in your primary care centers, how nice it is to see them get better and how well they do with problem-solving treatment. So we look forward to giving you that information, but really wanted to just make sure that you had some foundation for collaborative care. Next slide. One of the reasons that we chose to show you this slide is because when they were going around recruiting sites to do collaborative care, to use problem-solving treatment, to use the PHQ-9 as a measurement tool, they went into a practice that had a behavioral health provider already. And the research people said, you know what, we can't really include you because you're not providing usual care. You already have somebody there who's doing some of this work. And the medical director said, no, please let us participate in your research study. And what we found actually was that when a next slide, or if you hit enter, it'll show here. You can see one of the practices that had the behavioral health provider did so much better when they put a system in place to really care for patients with depression. And that's what we're going to be talking about today, is really using an evidence-based practices and models to be able to care for your patients with depression, to use the PHQ to measure how they're doing, and then use an evidence-based practice like problem-solving treatment to help patients get there. Next slide. So when we think about what we're doing around collaborative care and using some of these models, you're going to see patients that have less depression, you're going to see better functioning, you're going to see them in less physical pain. And what you're also going to see is that it's a lot more cost effective. And so what we're hoping we're going to try to do today is to really work with you to introduce problem-solving treatment and collaborative care into your settings and really come away with some ways to work with your patients. Because one of the things that we like to say is, we're helping you to build a toolbox, and problem-solving treatment is one of those modalities that you can have in your toolbox that will really work well as a short-term, treatment for patients with depression. Next slide. So we wanted to talk very briefly about the PHQ before we really get into problem-solving treatment and sort of the main theme for the day, and I'll turn it over to Eunice at that point. We really wanted to talk about the PHQ-9. Many of you are familiar, but one of the important things is that as you incorporate these evidence-based practices like problem-solving treatment into your toolbox, into your treatment, is to really measure how patients are doing. And one of the ways to do that is to use the PHQ routinely in your sessions and to start your sessions out using the PHQ-9 so that you can look to see where people were last time and where they are now, not just for the total score, but particularly around symptoms, around concentration, around eating, And so that will help you really start to focus your work with patients and help them identify problems that they can work on and goals that they're going to be able to work on in care. So next slide, you can see the PHQ. And one of the nice things about doing this at the beginning of each session is that you'll see it really will help you formulate a session for problem-solving treatment with your patients. It will also help you identify ways that they're doing better or things that you need to address in care. So we really wanted to just bring up the PHQ again so that you really had some new thoughts about how you might incorporate it routinely in care if you're not. And also to talk a little bit about benchmarks. So several people have emailed me and said, you know, we're thinking about using the PHQ much differently. We're thinking about, you know, really making sure that we're starting off sessions. You know, how are we really looking at outcomes? And so one of the things to keep in mind is that one of the national benchmarks is to see a 50% reduction or 10 points within 90 days. So in that first 3 months. So this way you're really working with patients using evidence-based practices to help meet some of those outcome measures. So I'm going to turn it over to Eunice, who's going to give you an overview of problem-solving treatment and take it away from there. And I really encourage you to ask questions as we go along. We'll be monitoring the chat box, and I'll be facilitating. So we'll certainly leave time at the end, but also we'll be bringing up and answering some questions throughout. So if you're not shy, feel free to, you know, ask a question or communicate through the chat box. So Eunice, I'm going to turn it over to you.
Thank you, Virna. Hello, everyone. So thank you for having me here today. And I wanted to provide you all with a quick overview of problem-solving treatment. Next slide. Which is one of the brief, structured, evidence-based interventions that clinicians can provide to effectively treat clients within the integrated primary care setting. Next slide. So problem-solving treatment is based on the premise that we all have problems and challenges in our lives, that there is no friend or family member, coworker, or celebrity that doesn't have problems and challenges. This is part of the human experience. However, it's when we feel a sense of powerlessness and feel overwhelmed by our problems that depressive symptoms can begin to emerge and or become exacerbated. Oftentimes, this becomes a cycle where the more we feel overwhelmed by our problems, the more we avoid them, and the more problems pile up. And as more problems pile up, we feel even more overwhelmed and stop engaging our problem-solving skills. Next slide. So what is problem-solving treatment? It's a structured process of breaking complex problems down into bite-sized, manageable pieces. And why do we do it? What are the outcomes that we're really looking for? Our outcomes that we're looking for are to strengthen clients' problem-solving skills, to increase their sense of self-efficacy, increase their sense of control over their life, and then kind of as a result of that, increase their sense of hope and ultimately reduce the depressive and anxious symptoms that often bring clients to our clinics in the first place. So problem-solving treatment, or PST, is designed to counteract that vicious cycle of powerlessness. Clinicians often ask me what sort of clients are a good fit for PST. As Virna mentioned, PST is an evidence-based practice to treat depressive symptoms as well as anxious symptoms. However, when you're thinking about who would be a good fit for PST, I would encourage you to think beyond diagnoses and to think about this frame. Is the client facing concrete problems in their lives? And do they seem to overwhelmed by the problems in their lives or seem stuck in them? If that's the case, PST may be a good fit and a good place to start. PST can also be helpful for clients who would benefit from greater structure in their lives or in their sessions. I think we all know clients who might go from topic to topic or maybe from crisis to crisis. So this would be a good fit for them, as well as for clients who might be uncomfortable engaging in traditional psychotherapy, particularly because this is a primary care intervention. PST is short-term and present focus with an emphasis on functionality rather than necessarily insight or sharing about deep-seated emotions or fears. So it can be good for primary care clients who may not really be exposed to traditional psychotherapy, but it might be a way to engage them in care with you. Next slide, please. So far, I hope that many of you are thinking that PST, at least as a model or as a concept, sounds fairly intuitive and logical, and it is, and that's exactly the impression we want clients to walk away with from our sessions. However, the biggest challenge for clinicians is not so much understanding the concept of PST, that when clients feel overwhelmed, They might start avoiding their problems, and as a result, those problems begin to snowball and affect their mood. But it's rather shifting their thinking about their role from one of a traditional therapist who maybe sits back and allows the client to guide the content and flow of the sessions to one of a teacher. So this can be the hardest switch for folks to make, as some of you will be learning a new set of skills yourself. So what does it mean to be a teacher? And what does it mean that it says here that this is a much more directive role? I like to think about it in this way, that I'm the expert on the process of problem-solving treatment and the steps of PST, which we'll review in the next few slides, but that the client is the expert on their own life. So I'm never telling the client what to do, but I'm guiding them through the steps of PST so that they can begin to apply it to their own lives. Next slide, please. So the main point that I want you to take away from this list of teaching methods that are commonly used within problem-solving treatment is that this role shift into a teacher is based on transparency and self-efficacy. So in PST, there's no mystery about which step we're on or why we're doing this certain step or this certain skill within the PST model. As clinicians, we're consistently sharing the rationale for PST as a model and the rationale for each step. We're also aiming to teach clients to be able to independently use PST so that once this client has been discharged, they feel comfortable and confident using PST as one of their coping skills. So all of the tips and strategies that we use, all of the worksheets that I'll point out, you can also see them on your screen under the handouts section that are available on this webinar. We're going to be sharing those with the client, and I encourage you to do so as well. Next slide. So we've talked about the rationale behind PST, and now I want to talk a little bit more about what it looks like in practice, so that even after this webinar concludes, that you're able to start incorporating some of these concepts and some of this modality into your treatment with clients. So problem-solving treatment is made up of two components: enhancing clients' problem-solving skills and enhancing clients' enjoyment in life, referred to here as activity scheduling, which is very similar to behavioral activation. So these two parts of PST address the two most insidious aspects of depressive symptoms. One, which you've discussed already, is that depressive symptoms take away a client's ability to tackle problems in their lives. And two, it also takes away the client's ability to experience joy or pleasure in their life. Next slide, please. So we're going to start with the piece on problem solving. And I want to walk you through the trajectory of treatment within PST from the beginning with a psychoeducational intro session to follow-up sessions where you apply the 7 steps, and then finally with the relapse prevention planning prior to discharge. Next slide, please. So in the very first session of PST, you're providing a psychoeducational overview of the model. And one of the handouts included in this webinar, entitled Introducing PST, walks you through the content to cover in this session. And so you start off by talking about the structure of PST. PST is usually about 4 to 8 sessions, and obviously this can vary depending on the symptoms that your client presents with. But in general, within the model, it's about 4 to 8 sessions that occur on a weekly or a once every 2 weeks basis. We also want to talk about the PHQ-9, why we use this, and how we'll be using this questionnaire at each session to track client symptoms to better understand if they're getting better, if they're getting worse, or if their symptoms are staying the same, and want to provide some psychoeducation about depressive symptoms in general. So many people often associate depressive symptoms just with their mood or this loss of interest or pleasure. And we also want to talk about how depressive symptoms affects the body. It can affect clients' sleeping patterns or their appetite, their energy level, their ability to concentrate, as well as how they think about themselves and the world, and can oftentimes lead to thoughts of self-harm as well. The next one that we want to talk about in this intro section is exploring the client's problem-solving orientation. And all of this is very conversational. You want to get a sense of how the client understands some of these concepts and kind of where they resonate with some of the psychoeducation that you're providing. So you want to get a sense of how the client thinks about the fact that they're having these problems and how they generally address problems in their lives. Are they avoidant? What do they notice when they avoid problems? What happens? How do they feel? Do they generally tackle problems head-on but feel overwhelmed? And you're also able to note if there are some maybe cognitive distortions that you might want to work on or tackle before you really get into the bulk of PST. It might also give you some information about areas where this client might struggle in terms of their problem-solving orientation, their history, as you move forward in the model. Next slide, please. So then you're going to discuss the 7 steps of problem solving, and I'll talk about that in just a few slides, as well as review the rationale for activity scheduling. So here you want to, how I generally introduce this is talking about the vicious cycle of depression. So oftentimes when people are feeling down, they start to feel more tired, they notice less interest or pleasure doing things that they used to enjoy, and as a result, they kind of start neglecting their interests, their passions, their hobbies. And as they stop doing those types of things, they tend to feel more down, feel a little bit worse about themselves or about their situation. They feel more tired, and around they go, right? So activity scheduling is about creating space and time for clients to incorporate activities for their pleasure, rest, or enjoyment. So this is really focusing on not the should-dos in this client's life, kind of their to-do list, right, but the want-to-dos, things that they used to enjoy that they've forgotten or neglected or kind of laid to the side. So during this introductory session, you're really laying the groundwork for your follow-up sessions. This session is an opportunity to provide not only psychoeducation about depressive symptoms, about problem-solving treatment, about activity scheduling, but also to increase clients' buy-in for the model as a whole and to develop that therapeutic alliance. And at the very end of this session, which can either be done in 2 30-minute sessions or 1 60-minute session, because there is kind of a lot to cover here, as you can tell, is creating a problem list. Next slide, please. So in one of the handouts, again on the screen here, there is one called PST Problem List that you can use. So I want you to think about the problem list as a general checklist. It's also very similar to a treatment plan. You're collaboratively compiling a general list of problems that affect the client in their day-to-day life. And if you open up that file that says PST Problem List, you'll see that it has several different boxes, several different categories where a client might notice problems in their lives related to work, related to relationships, related to health, self-care, engagement in pleasurable activities, spirituality, substance use, sexuality, etc. And you're going to be collaboratively compiling a general list of problems that affect the client in their day-to-day life now, that you're going to begin to apply PST to in future sessions. So this is a working document. You know, there might be clients who come in that there's another problem they really want to add, and you might ask them if they want to add it to the problem list so that we can address it in a future session, or if they want to work on it in today's session. So it's a working document, it's dynamic, that you can continue to add to, and also to cross things off as well if some problems get resolved. So during the session in particular, clients can often give you a lot of information. They're not used to the PST model yet, they're not used to the PST structure, and they might begin to go into the details of their problems. So during this session in particular, you really want to keep the client on task and redirect the client back to the problem list exercise when they begin to get lost in the details. So the idea of the problem list is to be a treatment plan, but also to help our clients articulate and visually organize their problems. They may find as they kind of complete this list, and I usually spend about 5 minutes. So again, we're not diving deep into any of the problems, but just getting a general list. They might have problems at work with their supervisor or with their partner, missing their health appointments, etc. And they might find that after they've completed this list, that they're doing well in certain areas of life, and that their problems are really concentrated in just a few boxes. We want to reflect that to clients as well. So after we complete the problem list, and if it's difficult to kind of complete the problem list within session, this is also something that you can assign for homework and kind of pick up here at the next appointment. I usually end by asking the client, you know, which of these problems feels the most manageable for them to work on next week? And I emphasize that we're building up a skill. So this problem that we work on next week might not be the most important or even the most urgent, but I want to ask them what feels doable to start making some progress in at our next session. And I do let them know too is that because we're building up a skill, I want to start off with something that feels more feasible so that they don't feel so overwhelmed as they're learning something new. Next slide, please. So that's that introductory session. And in the follow-up sessions, kind of in the middle of our treatment trajectory, we are going through the first 6 steps of PST listed here on this slide. And I'm going to be walking through kind of each one in the next several slides. In an ideal situation, as you feel more comfortable implementing PST, as well as the client feels more comfortable with the model, you'll be going through steps 1 through 6 listed here in each 30 to 45-minute session. However, for some clients, they may take a little bit longer with certain steps. And if that's the case, then we want to meet the client where they're at, and we can kind of slow down these steps and slow down the pace of sessions to meet the needs of the client. Next slide, please. Actually, next slide. So step 1 is clarifying and defining the problem. So as we begin this, you already have your problem list in front of you. And you don't want to take a problem directly from the problem list because that's a general category. But you're going to start looking at, maybe it's going to be relational problems. Maybe it's going to be problems at work. And they're going to pick one that they want to work on for that day. As you start with that general kind of topic from the problem list, you're going to begin to explore the who, the what, the where, the when, the why of the problem. Kind of get a texture for who's involved, where is this happening, what's going on. And for some problems, for example, there's a box for finances and there's a box for housing, right? These are kind of big problems. So during this process, the client might give you a lot of different information about their financial problems. Maybe they're having trouble paying off their student loans and they're trying to find a more affordable place to live. It's hard to pay their rent. They're not sure if they really like their job. It's hard to buy the food that they want to eat, or maybe they don't know how to find a job. They're procrastinating with the job search process or making a poor impression with interviewers, or they don't even know how to start paying off their student loans. So there's a lot of different problems that are interwoven within this big topic of finances. So during this part, you want to kind of tease those problems out. It sounds like you're having some trouble paying off your student loans. It also sounds like you're thinking about different places, different more affordable places to live, and trying to find ways to buy the food that you want to eat, right? So which of these different problems, of these 3 problems, which of them would you like to work on today? So again, you're kind of funneling down from this topic of finances, teasing out the different problems that you hear in there, and landing on one. Maybe, again, it's that they're having trouble paying off their student loans. If you can go back one slide, please. So as you start to clarify the problem, you want to begin to develop a problem statement. So this is a statement that's phrased in I language and in behavioral terms, something that we can change, that we can work on in a concrete way. Oftentimes, clients will bring up their emotion or emotional language. So I feel sad a lot. My partner doesn't make me feel good about myself. I get really angry when my kids don't help out around the house. And if that's the case, you want to kind of redirect that emotional language into behavioral language. So what do you do when you're feeling sad? Or what do you stop doing when you're feeling sad? Or if I was a fly on the wall, right, and I saw you when you were sad, what would I see? So you really want to make this behavioral, an I statement, and something measurable. And that measurable doesn't have to necessarily be a number, but it's something that we know has happened or hasn't happened. Next slide, please. And next slide. And the last thing to really consider as you're kind of clarifying and defining the problem is that the client needs to have some degree of control over the problem. Oftentimes, clients will talk about how they're having an issue with their boss at work. Their boss isn't appreciating what they're doing, or maybe they're getting into a conflict with their spouse who's drinking a lot or using substances, or their kids aren't helping out around the house, or their housemate isn't cleaning up. And that's when you want to provide an important psychoeducational piece that, unfortunately, right, those people aren't in the room with us. You're in the room here now, so you want to work on something that's within your control. Something also that also often comes up is that some clients are in chronic pain or have chronic medical conditions. So they talk about the problem being that they're in pain. So you want to follow that up kind of in a similar way that we do with the emotions is, so I understand that you're in a lot of pain on certain days when you wake up. When you're in pain in those moments, what do you do or not do that's a problem for you in your day-to-day life? Right? So again, directing it back into something that's within their control, something that's behavioral. Maybe it's that they're getting up later that day. Maybe they're yelling at or being more irritable or yelling at people that they live with. Maybe it's that they're not going outside, or they're stopping, maybe they're not going to one of their events that they usually would go to. So I do want to kind of emphasize this reminder here to take time on this first step, because this really sets the foundation for the rest of the process. Once you're able to really understand the problem, the rest of the PST steps tend to flow from that. But if you're not able to find a problem that is within an I statement, kind of measurable, feasible, within the client's control, then you'll kind of be circling around through the different steps. So take time on this first step to really understand the problem for the client. Next slide. So step 2, so once you've identified the problem, step 2 is identifying the goal. And this follows directly from the problem definition. So if that was the problem, right, or if this problem was solved, what change would you see? How would you like things to be different? What would you like to do differently? And just like the problem statement is objective and measurable, that we can tell whether it's happened or it hasn't happened, the goal statement is also objective and measurable. Next slide, please. And the goal statement must logically align with the problem statement. And I want you to think of these two statements as kind of mirror images of one another. So if that's the problem, what is the goal that we're working towards? And on the bottom of the slide here, there's several problem statements, the goal statements that do align. So I'm waking up late is the problem, and the goal statement is I would wake up on time. This doesn't always match up, right? There are times when the client might say the problem is I drink too much when out with friends. And then the goal statement that they come up with might be I want to make new friends. So those don't quite align, right? One is about reducing their substance use, and one is about kind of meeting new people or adding new people to their social network. So then you want to go back, and it might be, in this case, that the problem statement and the goal statement doesn't align. So do they really want to focus on the alcohol use, or do they want to focus on making new friends, right? And we want to go back to that problem statement. Other times it might be that they pick something that's out of their control, and you want to provide some psychoeducation about that. And as you can see from these problem statements and goal statements, they're I statements, they're behavioral, they're measurable, but they're certainly not SMART goals. And that's okay at this point. We're still staying very general. PST follows kind of this funnel image where you're starting off with that problem list, those general topics and categories where they might experience problems in their lives, identifying a behavioral and measurable problem, and then the goal that they want to work towards, but still staying fairly general at this point. Next slide. So step 3 is brainstorming. So the purpose, at this point you have a problem statement, you have a goal statement that they want to move towards, and you're thinking up different solutions that the client can take, different choices that the client can make to move them towards their goal statement. And the purpose of brainstorming is to really encourage the client to think. Brainstorming is a way of waking up the brain. I often tell clients that, when they have thought about a problem for a long time, or they've been stuck in a problem for a long time, they often get tunnel vision, where they can only see the problem in one sort of way. And they're really not able to think of any other solutions besides what they've tried so far. So I ask them to kind of put on their creative hat and just throw out as many ideas as they can, as many solutions that'll help them to get to their goal, as many choices as they can make, right? So that'll help them to get to their goal. And we want them to throw caution to the wind, just throw out ideas even if they seem wild or out of reach, really engage their creativity. And during this part, we really want the solutions to come from the client, and we're looking for quantity over quality. We just want to get those juices flowing, just want them to start thinking outside of the box. And our role here is really to create a judgment-free zone. And again, if you look at the handouts on your screen, right now we're looking at the one called PST Problem Solving Worksheet, where you'd be able to list or have the client write down all the different solutions that they can think of. Next slide, please. So continuing on with step 3, brainstorming. During this point, we're really just asking for more ideas. So when clients are giving ideas, we're asking, okay, great, keep those ideas coming. What else? What else comes to mind? What else can you do? Right? We're not really exploring any of the ideas. We're just generating ideas and supporting the patient in their process. And we're writing or having the client write all of these ideas down without without discarding any for being unreasonable or being unfeasible or impractical, or just getting all of the ideas down. And I do want to, again, kind of emphasize here that we don't want to provide any qualifying statements such as good or great idea about the content of a certain idea. We're affirming clients in their progress with the process, generating as many ideas and as many creative ideas as they can without kind of providing any sort of bias about what we might think would be a good idea or what we think might work. Next slide, please. So in step 4, we have this list in step 3 of all the different solutions that a client can make. And now in step 4, we're weighing the pros and cons. So I asked the clients now to kind of put on their analytical hat. So we've talked about all the different solutions and all the different possibilities that are open to them. And now we really want to think about what are the pros and the cons. What are the advantages and disadvantages of trying, this next solution next? So you're going through all the different solutions that your client has come up with, and you want to start off with the pros. Right? What makes this particular solution a good solution for you to try next? And that's because people struggling with problem solving tend to gravitate toward the cons. So you want to start off with the positives. Once we exhaust all the positives, and again, we're really just prompting, okay, what else might make this a good idea? What are some other advantages? Then we want to move on to the cons. Next slide. And with the cons, we want clients to begin to think about different variables, right? How much time, this is true actually for the pros or the cons, how much time would be involved? How much effort would be involved in you trying out this next solution? How much money would it cost? How would you react? How would somebody else who's involved react? And during this time, we really want the clients to be honest with themselves about the benefits and disadvantages of each one of these options. You don't want them to think, well, it sounds like a good idea on paper. We really want them to think about, as the expert of their own lives, would this really work for you? And during these times, again, we're asking with open-ended questions, not providing the answers ourselves, but just having the client begin to think about time, effort, money, how they would respond. Next slide, please. So after you've gone through the pros and cons, now you're at step 5, which is when the client chooses one that they'd like to try next between this session and your follow-up session, usually again in 1 week or 2 weeks from today. And you're just asking which solution seems like the best one. Which one would you like to try next? Which one really stands out to you as the one that you want to try next? And so the task of this step is to support the patient's choice of the solution. If for some reason, even after they've gone through the pros and cons, and after you really encourage them to think about that time, cost, money, effort, and you still feel like they pick one that may not be the ideal solution for some reason, and usually we really do want to take a step back and let the client kind of drive this process and really be the expert. But if there is some safety concerns, if if there's something that you feel like they might be missing, that's when you can also begin to explore, what made you decide to pick that one? What made that one stand out to you? There's a lot of cons listed down for that particular solution. What made you decide to pick it anyway? Right? We want to get a better sense of where they're coming from. Next slide, please. And then we move into step 6. So thinking again about that funnel, we started off very general, talking about, let's say, a financial problem. And then they moved into one behavioral aspect of that problem and the goal that they want to move towards. They thought about all the different options in step 3, then weighed the pros and cons in step 4. They picked one that they want to try next. And now we're into step 6, creating an action plan. And this is really where we really want to spend a lot of time here as well. This is the reason for all the previous steps, because we want them to be able to follow through on making a change in their life, a change that they've identified that they would like to make. And this is when you're boiling that problem down into a SMART goal. So the who, the what, the when, the where, and the how. And we want to make this action plan as bite-sized as possible. So they picked the solution, and I really want to ask, what's the very first step in moving towards this change that you picked? Something that you can ideally do within the next 24 to 48 hours, because research shows that when clients kind of maintain that momentum and complete it in the next 24, or plan to complete it in the next 24 to 48 hours, there's a higher likelihood that they'll succeed. So some examples of action plans might be, the client will call the financial aid department at their school on Thursday at 3 p.m. to ask questions about paying their student loans, right? We got the who, the client. What are they doing? They're asking questions about their student loans to the financial aid department at their school. When? Thursday at 3 is when they decided would be a good time for them. And how are they doing it? They're giving them a call, right? Another example might be, client will turn off the lights and all electronics at 9 p.m. tomorrow to start their nightly sleep routine. And this could be to address some of their sleep disturbance. Client will go to an AA meeting on Wednesday afternoon at X location. Or, right, if that feels too big, we might want to scale that goal down. Let's say they pick that they want to go to an AA meeting to reduce substance use. But if that feels too big to actually go, the action plan might be, the very first step might be, the client will look up nearby AA meetings on Wednesday afternoon via a certain website for 20 minutes. Right? They might not even pick one that they want to go to that day or during that week, but they're just going to look up this information. And just for 20 minutes, so it doesn't feel overwhelming. Again, having that time-limited piece to it. Client will use breathing techniques to take 10 breaths when washing the dishes after dinner tomorrow. And then after you pick kind of an action plan, you decide on an action plan, you really want to explore what's going to help them to succeed. So what's going to help you to follow through on this action plan? Thinking about the people, thinking about why that time works for them. And then you also want to explore, and you want to affirm those aspects that will make it a success. And then you also want to switch gears and ask, what might get in the way? Right? And they're going to anticipate some barriers. And you want to kind of very quickly brainstorm through some of those. So it might be that, on Thursday at 3 p.m. something happens, something else comes up. Okay, well, what can you do to work around that so that you're still able to follow through on the school? Maybe they're kind of in a bad mood at that point. Their mood is really low. They don't want to do anything. They're going to feel unmotivated. So I might ask them too, okay, so if you anticipate that barrier, what are some things that you can say to yourself to encourage yourself to follow through on this goal? Right? So we're troubleshooting any barriers that might come up. And you're letting the client know that either way, we're going to learn something new about this process. Next slide, please. So in step 7, so we went through steps 1 through 6, ideally, within your 30-minute to 45-minute PST session. Now it's next week. You set an action plan, and now it's next week. And you're starting off by asking, how did that action plan go? Right? If they are able to follow through, then we want to celebrate that. We're cheerleading them at this step. And we're saying, what helped them to follow through? How did that feel for them to follow through? We want to connect that back to their mood, right? If they weren't able to follow through, that's okay too. We don't want clients to have this sense of failure, but we want them to learn something new from this process. So if they weren't able to follow through, what got in the way? Was it one of those barriers that we talked about last time? And what happened, right? Did you try some of the things that we troubleshooted during that last session? And how did they work? It might be that it was something that they completely didn't expect or anticipate. And how did that feel that you weren't able to do it? After step 7, for some clients, it might be that they want to continue working on that large problem, right? So if it was that financial problem, they called the financial aid office and they figured out some just general ideas of how to pay back their student loans. And now the new problem that they want to work on today is, I don't actually know how much I owe, right? So it might be looking a little bit more closely at their specific financial situation. For other people, it might be that they tried their solution and it didn't work. So maybe they want to go back to reevaluating that problem again. Maybe it's looking through those, going back to step 3, brainstorming, and looking through those different solutions and picking a different plan or a hybrid plan that they want to try and creating a new action plan for that. Or it might be that that problem feels like they made some progress on it, right, the finances, and they want to move on to something to do with relationships this week and how to re-engage with some friends that they lost contact with. And if so, then you'll go through steps 1 through 6 again with that new problem for that week. Next slide, please. So we've talked about that problem-solving treatment has those two branches. We've talked about the 7 steps of problem solving, right? Identifying the problem, identifying that goal, going through the brainstorming, the pros and cons, picking one, figuring out an action plan, and then reevaluating it. And kind of, you're going to repeat that over the next 4 to 8 sessions. And so now I want to move into activity scheduling. Next slide, please. So with activity scheduling, you're talking about that vicious cycle of depression again. When clients feel bad, they start doing less. When they start doing less, they feel worse, and around they go. So while problem solving really focuses on breaking down complex problems, oftentimes things that don't necessarily bring them immediate joy, right? But there are things that they want to tackle, things that they want to address in their lives. Activity scheduling focuses specifically on things that will bring the client pleasure, rest, or enjoyment in the moment from week to week. And those activities can be physical, they can be social, they can be related to hobbies, spirituality, or self-care. So some examples, and these are also going to be SMART goals, SMART goal action plans. So some examples are that the client will spend 1 hour reading a certain book on Sunday afternoon, that the client will walk to this park near their house on Saturday morning after going to the gym, that they will dance to their favorite song on Wednesday evening for 5 minutes, that they're going to go to the movies with a friend on Friday at 6 p.m., that they're going to buy a bottle of wine and their favorite cheese at this grocery store on the corner of their neighborhood on a certain day. Maybe it's even that they're going to take a nap. You know, they have a lot of things on their plate and they've just been neglecting their rest. So they might take a nap on a certain day for, 30 minutes. Maybe it's reading the Bible or reading a certain passage in the Bible. Maybe it's painting their nails, taking a bath, eating lunch outside, looking at the stars. We really want it to be something bite-sized. A lot of clients have trouble with the idea that they can do something pleasurable when they have all of these other tasks on their to-do list that they haven't checked off. So for some clients where it feels like PST might be too overwhelming, I start with activity scheduling. And this is kind of, we get some momentum going with activity scheduling. We address some of those cognitive distortions with activity scheduling before we move on to the problem-solving treatment and the problem-solving steps. And with these as well, we want to encourage them to schedule something within the next 24 to 48 hours to increase that likelihood. And we're talking about at the next session, right? So at the end of every PST session, ideally, you have a problem-solving action plan, and you're also going to have an activity scheduling action plan that you'll be following up with at the next session. So for this, I'll ask too, if you were able to follow through on your activity scheduling activity, what helped you to do it, and how did that feel? And celebrating that. And if they weren't able to do it, we'll still learn something new. What got in the way, and how did that feel? And maybe it was that the goal, the activity, or the action plan felt too big. So let's shrink it down, make it even more bite-sized, something really, really small. Or maybe make it more time-limited that you can enjoy. Or it might be a self-care activity. They're doing too many things. Next slide, please. So at the very end of treatment, next slide. So at the very end of treatment, we're moving into the relapse prevention plan. And this is when the client might be completing PST treatment. They've completed their 4 to 8 sessions, or their depressive symptoms or anxious symptoms are subclinical. They've addressed a lot of the problems on their problem list, and they're feeling kind of capable of addressing these problems on their own. It might also be that the client simply wishes to end treatment. So when we're moving towards the end of treatment, I want to end with a relapse prevention plan. And one of the handouts on the side, again, is called PST Relapse Prevention Plan, which talks through the rationale for the relapse prevention plan and provides a worksheet. So we want to talk about with the client why this is important. We want to anticipate relapse and episodes of care. That there are times right now you're feeling really well, you feel like you're you're doing all these things that you wanted to do, you feel like you're able to tackle these problems, but there might be times when something happens in your life and you're going to notice these depressive or anxious symptoms kind of creeping up again. So you want to anticipate that, right? Let them know that that's fairly common. And when you're feeling better right now, we want to write down all the things that you've learned in our work together so that you have this resource to take with you. So you're talking through the warning signs, right, things that they start to do more of or less of when their depressive symptoms or anxious symptoms kind of come back. Maybe they're taking less care of themselves, maybe they're using substances more, maybe they're neglecting their relationships. And then we want to review the strategies that have worked previously. So are they still taking their medication regularly? Are they still meeting regularly with their care team, their primary care provider, maybe their nutritionist, maybe their acupuncturist, maybe they're not following up on their referrals? And are you using these coping skills, both the activity scheduling pieces, as well as have you been using PST to try to tackle some of these problems on your own? And I give the clients a copy of this before they leave. And of course, the door is always welcome for them to come back if after they've tried some of these coping skills, they realize they need some additional support. So now we've kind of gone through the trajectory of treatment with PST. And for our last few minutes, I wanted to open it up to any questions that people might have about problem-solving treatment within your particular setting.
Thank you, Eunice. You did a wonderful job. I think sometimes when clinicians hear about problem-solving treatment or start to do this work, they think, gosh, it doesn't sound clinical or it sounds too easy. So maybe, Eunice, just while people are putting in some questions, you can talk about what your thoughts were the first time you heard about PST.
Virna, is that question for me?
Yes.
That's a great question. I actually thought PST made a lot of sense to me, and that's why I started off with the rationale. I think a lot of our clients can be very easily overwhelmed, and it starts off as one small thing, but then it snowballs, and then suddenly it feels like it's out of control. And so to me, PST just makes a lot of logical sense that we're breaking down things that feel really overwhelming and making them bite-sized so that clients can be able to see some sort of change in their lives and to see that they're able to make those changes from week to week.
Great, thank you. So Libby, I don't know if you unmuted the lines and we can take some questions for the last couple of minutes.
So if people could send their questions to the chat box, that would be best since we do have a large number of people on the webinar.
Yeah, that's
I don't have any questions yet. Yeah, we don't have any questions yet, so please feel free to send some to us.
Okay, and we'll just pull them out of the chat box.
So we just had one come through. It's, what's the youngest age you can successfully use this model?
I think that's going back to that framework of who would be a good fit for PST. So for clients who are able to kind of engage those problem-solving skills, and I think it also might depend on what sort of problems they're coming in with. But I think any client who is able cognitively to really think about and articulate, what is the problem that I'm facing? What do I want to see change? And what are some things that I can do? I think it would work for certainly adolescents. I think for children, it might really depend on just their cognitive level.
That's the only question we have for now. Is there anything else you'd like to add before we wrap up?
So Eunice, are there any tips? Oh, sorry, Joan, go ahead.
I'm sorry. Go ahead, Virna.
No, I was wondering, Eunice, if you had any tips for, sometimes it's really hard when you start doing this work to not feed information to patients and give them suggestions. I'm wondering if you have a, sort of a last-minute tip for clinicians about how to really elicit, the brainstorming session from patients and what you might have learned along the way.
I really try to encourage clients to think outside the box. And I provide them with that rationale that I know that you've been facing this problem maybe for several months now, several weeks, several years, and it feels like you're kind of stuck. So we really want to take a step back and try to see this problem from as many different angles as possible. and see what kind of choices are open to you. And so I encourage clients to say things that they might be thinking. So is there something that you're thinking right now that you already has dismissed that it won't work? Or is there something that you're just not saying right now because you think that, that it might be silly, right? So we're getting all of those ideas on the table. I think I also, one of the other handouts that I didn't kind of highlight during my talk was the PST therapist prompts. So that provides some questions, kind of some standard common questions that clinicians might use for the different steps of PST. And it's reminding myself, too, that this client really is the expert of their own life. There have been times when I kind of really tried to keep my mouth shut and then ultimately kind of asked, but what about this con? Or what about this, kind of glaringly obvious solution that you didn't write down? And it turned out that the client had already done that, right? It's something that they just done earlier that week. So they were looking for new solutions. So I think those kind of experiences help me to check myself that the client really is the expert. And the other thing is that I rely on the transparency piece. So if there are things that I'm thinking, right, certain solutions that come to my mind, and the client is, we've prompted, I've asked them different questions, I asked what else, and they're still clearly struggling, then I might say, would it be okay for me to offer a suggestion? And then kind of see if they would want to add that suggestion to the list. Or asking them, what have they done in the past? And, if they had a friend, what would they say to that friend? Right? So we're always being transparent in that process too. I think there's both humility there and then also that communication piece.
So it looks like we have one more question. We have about a minute left. So one of our audience members noted that it sounds like you're using CBT, CBT, and coping skills also. So can you talk about the interactions of these different types of therapies?
I think a lot of people notice that, right? That PST is a bit of a hybrid of different evidence-based treatment models that you may already be using. And I think that's very deliberate, right? PST has looked at what works and kind of boiled down some of the essential pieces related specifically to problem solving and to depressive symptoms to create this PST model. And I think the thing that PST does differently is it uses a lot of those same skills, but it puts it into a new framework and a new structure. So a lot of the skills are the same, but it's the concept or how you're introducing it to clients that might be a little bit different.
Great, thank you so much. Is there anything that any of you would like to add before we wrap up?
I would. This is Joan, and I just want to say thank you to Virna and Eunice. I learned a lot this afternoon and appreciate your taking the time to be with us. And for the rest of you all, I hope you have a great afternoon and look forward to our next webinar, which will be on using motivational interviewing in primary care. Thanks, and Libby, thank you for doing the support for us. Bye.
Great. Thank you. Bye-bye.
So much, everyone.